Particularly is our international faculty from UK. He's also our faculty for the ERCP courses, an excellent teacher, and he would be talking about a few basics of colonoscopy, like the principles and the complications and indications of colonoscopy. That's it? Yeah.
Thank you very much for your kind introduction. First of all, my sincere apologies for being late this morning. I had a few hiccups yesterday. My flight was cancelled. I had to rush down to Islamabad to get another flight. And then, as I mentioned, my team lost. So it's a shame. It says DUHS here. I'm actually a consultant in North Manchester General Hospital, but I'm very proud to be associated with DUHS. This is a place where I've been working for the last 7-8 years with Professor Saeed Qureshi and Dr. Saad Niaz, and that's where we developed our courses. Learning objective for this course, basically when you are attending this course, you will be going through certain principles like consent, indications, contraindications for colonoscopy, sedation practice, diathermy, theory and practice. Initially, we used to present that as a lecture, but nowadays, to make it more practical, more interactive, most of these will be taught to you as you go along. So I'll proceed straight on to complications of colonoscopy. Like any invasive procedure, colonoscopy has got potential for complications. And obviously, whenever you carry out a procedure like that, there should be sufficient justification to carry it out. One shouldn't carry out any procedure without due indication. And rather than going into the detail, one of the things I would like to mention at the outset is that abdominal pain is not an indication for colonoscopy because you do not gain anything out of it, right? So coming to complications, the main complications that are associated with colonoscopy are mainly two, bleeding and perforation. Perforation is the most dreaded complication because it involves, breach of a viscus and potentially might require surgery and potentially can be fatal. Normally, at the time of consent, you do not tell patient that you can, death can be a complication, but you do not tell them at the outset. If the patient asks you directly, can I die from it, then you can quote that, yes, there is a possibility, but the possibility is something around 1 in 5,000, right? So it is there, but not an outside, complication. The main ones, as I mentioned, are perforation and bleeding. Risk of perforation, random series have quoted it around 1 in 1,000. That's a simple round figure. If you look at various series, it comes in 1 in 1,500, 1 in 2,000, 1 in 1,000, but most of the series quote the figure as 1 in 1,000. That is for a random set of patients. However, if you are looking at more selected group, like if you are doing an EMR or taking a big polyp out or doing it in carrying out procedure in a patient with ulcerative colitis, then the risk is much higher. It can be as high as 1 in 250 or 1 in 100, especially with large EMRs, right? So it depends on the scenario as well. Now, significant hemorrhage. Hemorrhage, again, is a well-recognized complication of colonoscopy, something that you would quote during your consent process as well. And the standard figure in random cases, random series, is around 1 in 500, which is acceptable to everyone. And however, again, if you are dealing with complex polyps, the patient has got bleeding diathesis or is on oral anticoagulants or antiplatelet agents, the risk is much higher, especially if they've got large pedunculated polyps, it is much higher. If the patient is taking antiplatelet agents, especially clopidogrel, then it is much higher, right? So With certain procedures, especially taking pinch biopsies or forceps biopsies, the risk is negligible. Even if the patient is on full dose anticoagulation, it doesn't make any difference. You can still take biopsies. Yeah.
It's not always dependent on the value of the INR, because if the INR is going to be more than 2.5, the risk of damage will be high. And if the patient is having the INR of less than 2.5, the risk of damage will be low.
Sorry, I didn't get, can you speak up a bit? Have you got a mic? Hello?
Thank you, sir. I was trying to ask you, sir, is the risk of the bleeding, especially following the biopsy, if the patient is on the anticoagulation therapy, is it not always going to be dependent on the value of the INR? If the INR is going to be 2.5, then the risk
No.
of the bleeding is high.
It doesn't make any difference.
Doesn't make a big difference.
I normally don't ask them to stop anticoagulants, especially if they are on, they're taken for cardiac reasons. Because the problem is, when you stop the anticoagulation for 5 days, you put them at risk of developing a stroke or a major cardiovascular event. Whereas, if you are doing a diagnostic colonoscopy, including taking biopsies, the risk of bleeding is negligible. So it is not worth taking the risk. Yes, if I'm doing a planned polypectomy, I would then ask them to stop because in that case, you are, looking at risk versus benefit. So this INR doesn't make any difference, right? Okay, so
I think if it is more than 1.8, if INR is more than 1.8.
it doesn't make any difference.
Well, the books have mentioned that
Yeah, book padhe yahan fir hamari sune. What we are quoting to you is from a series of trials, right? So book jo hota hai, book is 20 years behind,
yes,
right? Whatever you do in your practical life is published data, right? So nowadays, 4 or 5 years ago, we would ask them to stop the anticoagulants. Currently, we don't ask them, unless we anticipate doing a therapeutic procedure. If I'm doing ERCP, I would always ask them to stop the anticoagulation, because ERCP is never done as a diagnostic procedure. It is always done with a therapeutic intent. MRCP is the diagnostic procedure of choice. So you have to be very clear in what you want to do, right? Okay. So I normally don't ask them to stop the anticoagulation, because if they've got atrial fibrillation and there is a risk of stroke, so even if you stop your anticoagulation and he develops a stroke, so you may cause a major complication. Whereas the risk of bleeding from it is hardly any, right? And 2.5, 1.8, 1.7, 1.3 doesn't make any difference. Either they are anticoagulants or not on anticoagulants. So don't get yourself confused. Hanji, farmaiye. No, unless platelet count का भी चक्कर ये होता है कि platelet count below 50 is critical. However, if they are not bleeding, then you don't do anything. You wouldn't do any invasive procedure in people who are got platelet count below 50 or 10, क्योंकि spontaneous bleeding शुरू हो जाती है. Generally speaking, if people have got liver disease, their prothrombin time is usually high, but that does not give an indication of the coagulable state of the patient, because if you remember, in patients with cirrhosis of the liver, there is a high risk of developing portal vein thrombosis. So apparently their prothrombin time may be 25, 30, but they are not anticoagulated or auto-anticoagulated naturally. There are other factors in the coagulation process which are active as well. So if you look at prothrombin time, you are only looking at one screen in a moving sequence, right? So these things if you look at the directly acting anticoagulants, dabigatran, there you can't measure them with prothrombin time. There's no measure for it. So these things prothrombin time is only good for warfarin. That's it. No, there's nothing, nothing. You can do it on as high as 5 of, INR. It doesn't make any difference. There is no particular, क्योंकि पिन biopsy में ये होता है कि you just take a biopsy and you look at it. If it doesn't bleed, so you are okay. Right, okay. I've been doing endoscopies since 1996. The only time I had a massive hemorrhage from a pinch biopsy was in a patient with who had one of these, antiphospholipid syndrome. So she had quite a bad hemorrhage, but that is just one off thing, and that is in over nearly 30 plus years of experience. So hardly any, right? Now coming to the complication of perforation in a diagnostic colonoscopy is almost unheard of, very negligible, hardly ever. It shouldn't occur in a diagnostic colonoscopy, because if it occurs in a diagnostic colonoscopy, that means you are doing it very badly. It only perforation occurs during therapeutic procedures. Diagnostic it means you are very rough or your technique is rubbish, right? Okay. So that only occurs in, like if you are carrying out polypectomies or putting stents in or doing dilatation, then that's fine. I mean, that's a recognized complication. Sometimes it is, again, in diagnostic colonoscopy, if you got an inherent weakness in the wall of the colon, like diverticular disease or stricture. Severe colitis is a contraindication to colonoscopy, because if somebody's got severe colitis, you shouldn't do a full colonoscopy. You can only do a diagnostic flexible sigmoidoscopy, and that also should be done by an experienced endoscopist, so that you do not insufflate too much air, because barotrauma can cause perforation, or it can cause toxic dilatation of the colon. So colonoscopy is contraindicated in active colitis, so do not do it. If you want to find out if the patient has got active colitis or not, you only need a flexible sigmoidoscopy, because as you all know, the rectum is almost 100% times involved in ulcerative colitis. If you want to assess the degree of inflammation, just do a quick rectal examination, and that's it. That's all you need to do. Either it's active or it's not active. You don't have to go to the extent, because the treatment at the end of the day is the same. You will have to give them IV steroid, biologics, whatever, okay? Right. Factors associated with poor outcome. When you have a perforation, what are the factors which determine a poor prognosis? And one of the, like in anything else, increasing age, the older you are, the worse is your ability to cope with any type of insult to the body, whether it's a perforation, whether it's infection or whatever. So any perforation in the elderly is bad news. Other comorbidity, significant, hepatic failure, renal failure, cardiovascular disease, respiratory problems would give you poor prognosis, because any remedial surgery that you would like to undertake would be compromised. The risk would be much higher for that, and the risk would be higher even if you don't undertake any surgical procedure. Another important thing is, whenever you see a perforation, try not to hide it. Don't push it under the carpet. If you suspect the patient, you've carried out a procedure, the patient is complaining of pain, which is disproportionate to the degree of pain you would expect after the procedure, there must be something wrong. So always be proactive. Do an X-ray, do a CT scan if you are suspecting a perforation. Get him seen by a surgeon, because the problem is, if you try to hide it, that you can't hide a perforation or a complication. He would go home, he would come back with a bigger complication and present somewhere else in another hospital and give you a bad reputation, and secondly, it will be also, more importantly, bad for the patient. He can die from it. So always, even because, remember, these are recognized complications. It can occur to anyone. So if you take all the proper measures after recognizing a complication, then nobody can fault you. Because if you felt that the patient complained of pain after you did a dilatation or polypectomy, the pain was disproportionate and you did an X-ray, you did a CT scan, you called for surgical opinion, you've done your bit. Nobody can fault you in the court of law or anywhere because you've done all your procedures properly. However, if you try to tell them, nahi ji, theek hai, jao, bas, theek ho jayega, then that is wrong, right? So always, and it's always good that complication occurs in front of your eyes, then you can pick it up straight away. Risk of further morbidity, mortality is reduced. So if the delayed recognition of perforation, delayed treatment, poor bowel prep, obviously, if the bowel prep is poor, the bowel is full of bacteria because there are millions and billions of bacteria which can potentially cause infection and peritonitis. Bleeding, risk of bleeding generally in random series we quote as 1 in 500, right, which is 0.05. However, if you are doing a polypectomy, the risk is 1 in 100. If the polyp is a big polyp with a thick stalk, the risk is much higher, maybe 1 in 25, 1 in 50. You are always conscious of that. You are prepared for it. And the important thing is, as I said, anything that happens in front of your eyes is good because you can treat it immediately. Especially if you carry out a polypectomy and you've in a polyp with a big stalk, as soon as you remove the polyp, keep your snare sticking out of your scope, because in a few seconds after the polypectomy, if the polyp stalk is going to bleed, you can put the snare around it and just apply tamponade. Just put it on tight, don't have to do anything. Hold it tight for a few minutes and it will stop the bleeding. You can then put a clip on it, you can diathermy it or whatever, but the important thing is don't move from there. So I always, whenever I take a big polyp out, remove the polyp, I just wait there for some time to see if there's anything, blood vessels will sort of, start spurting or oozing. So always keep your polyps there. So it's always useful if they, bleed in front of your eyes, or, if most of the time, I mean, almost 90+% of the time, you can treat the bleeding endoscopically. Very rarely, I don't recall calling a surgeon to treat a bleeding after any of the polypectomies in the last 20, 25 years. So hardly ever. You can treat it there and then yourself, right? Now, the problem is with delayed bleeding. It's a well-recognized complication. Whether you do polypectomy, whether you do ERCP, anything, delayed bleeding can occur any time between 2 to 10 days after the procedure. You carry out a procedure perfectly well, everything looks, hemostasis looks perfectly nice, no problem. The blood pressure, hemodynamically, they are fine. You send them home, 2-3 days later, or even up to 10 days later, they come in with a massive bleed. So that is a well-recognized complication, can occur, and it's important to tell the patient about it. Tell them that if they see any sign of blood, or they should report immediately to the emergency department. Now, there are certain polyps which are particularly high risk for bleeding, those with a large stalk and a position with poor access. Poor access is an important indicator of the difficulty of polypectomy, because a lot of the endoscopists might find access to a polyp very difficult, and that's well recognized. They may be behind a fold, they may be in an awkward position. So in such polypectomies, I usually tend to use, especially if they are distal, a gastroscope to do polypectomy, because that's more maneuverable. So always make sure that you are qualified to do that polypectomy. So the endoscopist should only attempt procedure within their personal range of expertise. It is just like there's a saying in English, don't punch above your weight. If you are a middleweight boxer and you start fighting a heavyweight, then obviously he'll beat the hell out of you. So don't try to do procedures which are not within your range of expertise. And when you carry out any of these procedures, you should have a full armamentarium of dealing with the complication. Like normally, you should have all these things available, clips, loops, APC, right? So all these modalities. Nowadays, my favorite is quag grasper. These are special type of forceps which you can use, especially in EMR, to grab blood vessels and cauterize them. And your assisting staff, again, they are most important. They should know what they are doing, right? Normally, in our department, what we do is, because certain things like loops, they are rarely applied, and the nurses are, we have nurses who assist us. They are not familiar with them most of the time when, do anything. So every 6 months, we hold training exercise, just like a military exercise. So we set up workstations in which they carry out procedures, which we rarely do, so that they are familiar with it in a time of emergency. Because that's the time when you need to be more fluent during these procedures. Bowel prep. Bowel prep in itself can cause complications in patients who are elderly and frail, and those who have got other comorbid factors like renal failure, cardiac failure. Because if you are using certain types of bowel prep, especially Picolax, which is phosphate-based, then they can cause hypovolemia, hyponatremia, hyperphosphatemia, especially in patients with renal failure. So that can be a disaster. So in patients with renal failure, you do not use phosphate-based bowel prep. We commonly use movie prep for everyone, or clean prep, which is far more effective. The other problem is elderly, frail patients may develop postural hypotension with it, and they can increase their risk of falling. So be aware of that. So obviously, when you prescribe bowel prep, this should be done by, the choice of bowel prep should be carried out by a clinician. We normally use movie prep, which are safe in everyone. The only problem with these bowel prep is that they are not palatable. They taste like plastic or salt water. So we advise them to add some orange juice or lemon cordial or whatever flavor they like. And they come in large volumes. Clean prep is 4 liters of drink. Movie prep is better in the sense that it involves taking 2 liters of drink, but still it's a large volume. Right. Mispathology. Again, this can be classified as a complication of colonoscopy. You can miss polyps, you can miss cancers. The risk is about 2 to 5%. And that is something which should be quoted to the patient during the consent process, that there's a possibility we can miss lesion. And that's why even if the patient has had a normal colonoscopy and he comes to you with rectal bleeding or change in bowel habits, do not ignore that. They still should be re-investigated. Right? So that is a possibility. It makes it all the more important to improve your colonoscopy technique, because there is a certain criteria in determining your level of colonoscopy, and that is ADR. ADR stands for adenoma detection rate. The higher your adenoma detection rate is, the better colonoscopist you are. All it means is that when you are doing a withdrawal of the scope, you are looking at the colonic mucosa very meticulously and very clearly. Because a lot of people, when they do a withdrawal very quickly, they can potentially miss a lot of lesions. So people with high adenoma detection rate, the BSG guidelines states, or the JAG guidelines in UK states that minimum ADR should be 15%. Most of us who do regular colonoscopies have got ADRs of well over 50%. So most of our colonoscopies, we pick up lesions. That's why your withdrawal time from cecum to rectum should not be less than 6 minutes. Minimum is 6 minutes. The more, the better. Right, okay, so preventing complications, it's always better to prevent than cause a complication. You can cause significant harm during colonoscopy. So always consider whether the patient really needs that procedure, whether it's indicated or not. Elderly patients who have got significant comorbid factors. They've got a higher procedural mortality rate. Um, so be careful in selecting colonoscopy. Most of the time, I wouldn't even do a colonoscopy in these patients. I would do a CT colonography. The other question is, even if you got an elderly patient who's got iron deficiency anemia, and you are going to do a colonoscopy, the question you must ask yourself, not just for colonoscopy, but for any procedure is this procedure going to change my management? Even if I find a cancer in this patient, am I going to operate upon him? Am I going to do him any benefit? In that case, please do a colonoscopy or a CT colonography. If it's not going to change your management, if the patient is bed-bound, wheelchair-bound, he's not even fit for a haircut, there's no point in doing a colonoscopy in him. So always select your patient using common sense, right? So do not do it in patients where you may cause more harm. Always remember, in fulminant colitis, do not do a full colonoscopy. Patients who have had radiotherapy, there is a higher risk because the mucosa is weak, it is ischemic, might be tethered or adherent to the surrounding tissues. Especially the fact that we do J maneuver in the rectum, retroversion. I do not do it in patients with fulminant colitis, and I never do it in patients with radiation-associated proctitis because you can cause perforation there, right? Anyone with previous abdominal pelvic malignancy, adhesions, bleeding disorders, they are at risk of complication. Anyone who are on anticoagulant obviously are at risk of developing bleeding after the thing. Tolerance or allergy to sedatives, people with respiratory problems who are more sensitive to the effect of sedatives, patients who have got diverticular disease, sometimes, especially not in this country, but in the UK and in the West, diverticular disease is very common and it can be very complex because at times you can't even tell which is the true lumen and which is the diverticulum, and people can go through it. So always be careful. Patients who are clinically unstable, who are hemodynamically unstable, who are respiratory or cardiovascularly unstable, you shouldn't try to do any invasive procedure in those unless you are doing it as a life-saving procedure. And always ask the question, would another procedure be acceptable? And the other procedure is CT colonography. We don't do barium enemas now. It's out, right? Fine, I'll stop here. Any questions? Good. I like that. Yes, you can scope him. Patient with renal failure.
What about preparation, bowel preparation?
Bowel preparation, you don't give them Picolex or phosphate-based bowel preps. You can give them clean prep or the polyethylene glycol pegs type of prep you can give. They are quite safe. We do loads of them. They've got a bit of platelet dysfunction, so slight risk of bleeding, but yeah, you can do.
What about severe colitis? We are going to do the limited procedure.
Yes, yeah.
So bowel preparation for that?
Sometimes you don't need any bowel preparation, or you can give them a phosphate enema. But most of the time, you don't even need it. You can just do it, because all you need to find out is whether he's got ulceration or not. And if he's got it, you've got to give them IV steroids, because sometimes if they are not responding to treatment, you want to convince a surgeon that you need to operate on this patient. So in that case, the surgeon would want some more documentary evidence, which is true, because if you are taking somebody's colon out, you have to have a solid base for that. Haji. Okay. आप लोग अभी सही तरह बोर नहीं हुए तो आपको मैं और भी बोर करूं. Right. Sedation जो है, because whatever we do in UK, in the West, is audited. whatever procedures I carry out, I've got my own personal, or everyone is audited, and any of my complications, my cecal intubation rate, my completion rate, everything is sent to me every 6 months. कि मैं ठीक करूँ, how much sedation I use, how much midazolam I use, how much fentanyl I use, that is all recorded and audited. So I'm tested against a standard, national standards. ठीक है? So if we are underperforming, then irrespective of how many years I've been a consultant for, I'm required to explain. And if needed, I might be asked to go on a retraining course. Irrespective कि मैं नवाज शरीफ हूँ या इमरान खान या जो भी हूँ, it doesn't matter. We all are subject to this audit. ठीक? So one of the things that came out of, there's a national confidential inquiry into patient outcome and death, very important. This used to be the standard practice in surgery, and it also became standard practice in endoscopy as well now. So we are also subjected to this inquiry thing, right? So in 2004, a big audit in UK was carried out, and they found out that 14% of the cases of who were undergoing sedation, endoscopy were over-sedated. And in fact, 14% to my mind is an understatement. Because when we were doing endoscopies in those days, it was very common to give 5 milligram of midazolam straight away. Or हम लोग तो खैर देते ही थे, the surgeons used to give even more than that. Because obviously the surgeons, with due respect to our surgical colleagues here, were generally more zealous and cavalier in their approach. So at that time, we found out that we were using too much sedation, and a lot of alarm bells were raised. So what are the main risks of sedation? Main risk of sedation, as you can see, is they can be cardiopulmonary, which is very evident, and they can be other complications. So the main one that we are interested in is respiratory depression, hypoxia, CO2 retention, depending if the patient has got COPD, aspiration pneumonia because their gag reflex is suppressed. They might aspirate gastric contents, cardiac arrhythmias because of simple fact that they become ischemic, increase or decrease blood pressure, angina, MI. Other paradoxical citation, that's very rare, sexual fantasies, antegrade amnesia. Very common with drugs like midazolam. Nausea, vomiting, all those effects are there, right? So what risks should be discussed during sedation? Normally, when you are consenting a patient, you discuss the risk of sedation, that it can affect your breathing, it can cause other interaction with other medications, especially if you are on antipsychotic, antidepressants, the effect can be accentuated. Generally speaking, we mostly mention respiratory depression and need for monitoring, which we always monitor all our patients. Low blood pressure, nausea, vomiting, memory loss, and the fact that we always tell them that we've got reversal agents available, and they should always be available. What sedation do we normally use? I think the one that we use in UK are slightly different. Midazolam is used here and in UK. However, if you use midazolam in combination with an opioid, because in colonoscopy and ERCP, we don't do them under propofol, we usually do them with sedation, combined sedation. So opioid should always be given before the benzodiazepine. We normally give the opioid and then wait for a minute. The reason for that is that if anything is going to go wrong, you observe that, and then you have only got one drug to deal with. Secondly, if you give it about a minute or so, it works synergistically, so you need a lesser dose of midazolam, right? So always good, rather than bolt in 2 drugs and then the patient suddenly goes off, then you've given 2 drugs, you have to reverse 2 of them. So always do it in a stage-wise. The other thing is, as soon as you give the intravenous drug, we normally follow it straight with a scope. Don't do that. Give it some time, because it takes a while for it to start working, right? Okay. But if you give it in a combined way, the effect is much quicker. This is clever stuff, forget about it. Main thing is excretion of the drug is delayed in obese patients, so the effect will be longer and more effective in obese patients. You might think that a person is obese, he needs a bigger dose. No, that's not right, right? So don't do that. The effect is more marked in elderly patients and those with heart failure, liver or renal impairment, because they can't get rid of the drug, simple as that. In the elderly patient, that is who are above 70 years of age, the dose, the maximum dose is half of what it should be given to those below. So if you are giving fentanyl, the maximum dose for patients above 70 years of age is 50 micrograms or 25 of pethidine. If you are giving midazolam, maximum dose for a young patient is 5 milligram, maximum dose for above 70 is 2.5. So always remember that. Generally, patients that you tend to endoscope are, most of them are elderly, because you are investigating iron deficiency anemia, you want to do colonoscopy, OGD on these patients, they would be more subject to the effect of sedation. Patient with obesity, hepatic cirrhosis, hypoxemia due to chest problems, and any procedure done during emergency is always high risk, because that patient may be bleeding actively or whatever. There are other things going on. Patients who are septic are high risk, especially if you are doing ERCP in a patient with ascending cholangitis. They are septic, they may be in septicemic shock, they are at high risk. So any emergency procedures are always high risk, and they should be done by people who are skilled to do them. So a maximum dose of 2 milligrams or 2.5 is we usually give. I normally start with 1 milligram and then just titrate the dose up according to the response. So that's just as we discussed. This is clever stuff, we leave it. Opioids again are given for their analgesic effect, right? Because if you are doing a procedure which is painful and uncomfortable, then just giving benzodiazepine is not enough, because it can cause a dysphoric reaction. So it's always best to give an analgesic with it. We hardly ever use pethidine nowadays. We use fentanyl, which is a much better drug. Nowadays, as you all know, you can give flumazenil for benzodiazepines. You can give naloxone or Narcan for opioids. Anytime I give a flumazenil or a naloxone during my procedure is an auditable procedure. It is noted. The nurses fill out an adverse incidence form with it, and it's put against my record. That doesn't stop me from using it if it's a life-saving procedure, because if the patient goes off, irrespective of what my record says, I have to save that patient's life, but it will be against my record, which means that I have to use minimal doses of sedation. Adat dalni padti hai na, so that's what we always do. So this, an incidence form is filled in, everything is noted against my, it is also noted in my appraisal, in everything that goes with me. So just to tell you. So what is appropriate sedation? Appropriate sedation is conscious sedation, which is drug-induced depression of consciousness, during which patients respond perfectly. The patient should be able to talk to you. And normally when we are doing the procedure, constantly our nurses, they are talking to the patient. What would you have been doing on this day when you are, if you are not doing a colonoscopy, just to strike a conversation. Bachon ka puchte hain, kitne children hai, ye wo, just to keep them engaged. And that, the reason for that is to make sure that they don't go off completely, so that you don't lose them. So that is very important. Because this is most important, even we always monitor their oxygen saturation and blood pressure, ECG, everything. लेकिन उन सबसे ज़्यादा important ये clinical वो है, contact है, right? So they should be able to respond to tactile stimulation, No intervention should be required to maintain the patient's airway, and spontaneous ventilation is adequate, which you can tell by their O2 saturation. And it's a very fine line between appropriate level of sedation, under sedation, and over sedation. So you have to dose. So normally, we start off with a low dose of midazolam, a low dose of fentanyl or pethidine, and then you just give them up. Recognizing respiratory depression, hypoventilation may cause hypoxemia, CO2 retention, which may lead to apnea and ultimate respiratory arrest. Clinical observation is most important, because the important thing is loss of contact with the patient. The moment that occurs, because if you wait for cyanosis, it is too late, right? So always, pulse oximetry again is important. Important thing is, when the alarm starts going off on your pulse oximeter, do not ignore that. Don't carry on with the procedure. Stop. Because if you don't respect that, then that is there for a purpose. Alarm is there for a purpose. It is to warn you. If you do not respond to it, then you are letting yourself into a major complication, right? So if you see the patient breathing going off, stimulate the patient, try to wake him, try to, most of the time it will work. If not, then use flumazenil and naloxone. Protect airways, ambu-back, and if needed, call the cardiac arrest team. Okay? What to do and what not to do. ये मत करें, ये करें, ठीक है? It is standard practice in UK, and it should be here as well. There's no reason why it shouldn't be here. That whenever you drop any drug, you look at read the name of the drug on the ampoule, how many milligram per mil, and also the expiry date. Or normally we visual check bhi karte hain and verbal check bhi karte hain. We read it out loudly, and another person checks with us. Okay? Generally, you take in a big department, the nurses drop the drugs beforehand, and they put the ampoules with it, with each syringe labeled. And then, before I inject the drug, I pick up the ampoule, I read it out to them, check it with them again. Because this is most important to avoid any wrong drug injection, right? Also, as soon as you give the sedation, the patient does not go off straight away, so wait for the effect for a few minutes. You know, let's give another dose. No, wait. Okay? And work as a team with your nursing staff or techs, to ensure adequate monitoring. Keep in regular verbal contact with the patient. Either yourself or your nurse should be doing that, ताकि आपकी communication रहे. And this again is a marking point on your DOPS procedure. Don't give midazolam before opiates. Don't forget to continue to monitor observation and respect the alarms. And do not ignore information given to you by the nursing staff. Oxygen O2 set drop ho raha hai, ye ho raha hai, patient is going off, और आप लग रहे हैं अपने मस्त endoscopy कर रहे हो ना, stop. If the O2 sat saturation is dropping, just increasing the oxygen flow is not enough. क्योंकि आप कहें कि 5 नहीं 15 liter लगा दो oxygen ना, that's not the right way to deal with it. You might mask other things, because that patient may be going off, right? Fine, we'll stop here. We'll do it in small doses, right? Any questions? No. Good. Yes, sir.
Is sedation really practiced in the UK for the daily routine basis? Every patient who is going either undergoing the upper GI anoscopy or the lower GI when he has to be sedated?
No.
No.
A lot of procedures I do without sedation. Colonoscopy is mainly done without sedation.
So it's not always
No, you don't need it. मतलब choice होती है patient की. और लेकिन अगर आपका technique अच्छा हो तो you don't need minimal sedation. Uppers again we do patient choice, but most of them I do without sedation, just with the then you can straight to the floor. Colonoscopy, ERCP I always give sedation. क्योंकि उसमें I think the patient will be much calmer and everything. Ideally, यहाँ पे जो propofol use करते हैं और US में भी propofol use करते हैं अमेरिका में. ब्रिटेन में हम routinely नहीं use करते, लेकिन I come from a very big department जहाँ पे हम we do over 1,500 ERCPs a year. So उसमें I have a GA list once a month. In fact, I'm trying to do that twice a month. तो उसमें जो patient नहीं tolerant होते हैं, जो complex procedure होती है ERCP में, so I do those under GA with full intubation and everything. And proper general anesthesia. Lekin generally in UK we use combined sedation. So for a lot of things मतलब colonoscopy तो आप बगैर sedation भी easily कर सकते हैं. सिर्फ ये है कि आप टेक्निक अच्छा हो, एयर ज़्यादा ना डालें, लूप्स ना बनाएं. आजकल हमारे पास मतलब routinely we have got the scope right. सबसे ज़्यादा जो कोलोनोस्कोपी में जो चक्कर है वो है उसका एयर इंसफलेशन. Especially if you are doing a combined procedure, आप OGD पहले करें and if you follow it up with a colonoscopy, so during OGD whatever air you put in tracks down to the colon or even a small valve, and that can make it very uncomfortable for the patient अगर if you are not conscious of that. तो अगर आपने combine करना हो तो make sure कि when you do OGD मिनिमल एयर डालें और मैक्सिमम उसको निकालें, लेकिन फिर भी काफ़ी चले जाता है. हाँ, तो ये भी केयरफुल.
सर अंडर वाटर टेक्निक भी यूज करते हैं
जी,
अंडर वाटर कोलोनोस्कोपी.
अंडर वाटर मैं करता हूँ, लेकिन आई ओनली डू इट इन डिफिकल्ट पेशेंट्स जिसमें मतलब वो जो सिवियर डायबिटिक डिजीज वो हो, ज़्यादा मतलब एंगुलेशन हो, लूपिंग हो ना, तो उसमें ये होता है कि if I find it difficult, so I come out, take all the air out in the niकाल सकूँ, and then just flood it with water.
So you first try air insufflation and
हाँ, नॉर्मली हम एयर से ही करते हैं ना.
if attempt failed then you go with
हाँ, अगर मुझे पता हो कि कहीं और फेल हुआ है इसी वजह से, तो then I will do water straight away ना. तो उसमें ये होता है कि फिर आप एयर बिल्कुल निकाल दें and come right out ना. तो वाटर में ये होता है कि बड़ा मजे से कोलोन आपका बैठ जाता है. और उसमें ये होता है कि we tend to use हमारे पास है एंडोगेटर जो ये पंप होता है ना, तो it's not all that costly. वो आप उससे भी syringes full वो करें, बहुत syringes बहुत ज़्यादा आपको डालने पड़ते हैं. एंडोगेटर वो वाटर उसमें आप पंप डालें तो it's very effective.
but that's total colonoscopy under water.
हाँ, लेकिन
But
उसमें
in depth
मेन जो चक्कर होता है, आप सिग्मोइड से निकल जाए
जी
तो फिर आपको आगे जरूरत नहीं पड़ती. Once you are in the transfer, you don't need underwater then.
जी
You can do it, but मतलब I just use it for that purpose. So up to the left colon, you can use it. Some people do underwater polypectomy as well, लेकिन
ये जो sigmoid की approach है जहाँ पे वो water use करते हैं air की जगह पे, that is beneficial in less loop formation in sigmoid.
नहीं, अगर ज़्यादा लूपिंग हो ना या एम्बुलेशन हो या वो हो ना सीवियर डायबिटिक डिजीज हो स्पैम हो, तो उसमें अंडर वाटर हेल्प इसलिए करता है कि
जो स्टार्ट का अंडर वाटर है नॉट
वो लूप्स को क्योंकि वो लोग हैवी हो जाते हैं ना तो वो बैठ जाता है. स्ट्रेट कर देते हैं उसको. So that's why it's helpful ना. लेकिन मैं ये करना होगा कि you have to meticulously get all the air out before you do that.
So we plan to we're done.
We are done.
Yeah, so we're now going to go and see a live case done by Paul. And then once we've done that, then we go on and start, in the batches of two, start going there.